So what we will do, Rod and I, we divided it in two parts. So I will tell you something about the methods and the organization of the guideline development. And Rod will tell you a lot about the results of all the guidelines we have already. So the first question is, why do we need international guidelines? Now, it will be very important to work together and to have a common vision for the surveillance of late effects and also for the care of survivors. And what we saw in the beginning is that every country or every clinic was making their own recommendations and every physician was going through all the evidence, and that's not really efficient. So we thought it's much better to collaborate. So at the moment we are successful because we are combining a lot of international expertise. We reduce duplication of effort. We also hope to reduce the variation of care. Of course, you can have other care for a specific patient, but please know what is the standard of care. And it's important to work together because we can then produce guidelines in an efficient way and also have a high quality because we have many people who can work together and do a lot of work. So the second question is then, what are the evidence-based guidelines? Now, evidence-based guidelines are a combination of two parts. And the first part is the evidence, and the second part are the recommendations. So you will always find in a guideline evidence and recommendations. I think in clinical protocols for pediatric oncology, we have a lot of advices, but the distinction between evidence and recommendations is not always clear. In our guidelines, in the evidence-based guidelines, we really would like to make that distinction. And finally, you would like to include the patient's values, the clinical expertise, and of course, the best evidence research, the best research evidence together. And that will form the basis for the discussion about the recommendations. Then how do we develop the evidence-based guidelines? Now, there are three important steps. The first step is to develop clinical questions, then search for all the evidence and make the recommendations. And developing clinical questions, we think that's really easy, but when we see the evidence-based guidelines that we developed in the group, then we see already that we discussed for weeks about the clinical questions. Because if you don't ask the right questions, you will get the wrong answers. And a guideline can have 10 clinical questions, but it can also have 100 clinical questions. So you can see that there is a lot of work to do. And how we develop the clinical questions is based on a PICO, and the PICO elements are patients, interventions, control, and outcome. The PICO is based on treatment questions, but we can also use it for late effects. An example is here. So then you say for the patient, it's, for example, females who have been treated for childhood cancer. And then they are treated with a low dose of chest radiation. Then we hope that we have also a comparison group with no chest radiation, and we look to the breast cancer risk. So this could be one of the clinical questions in a guideline to think about the surveillance for breast cancer. Another important question is, what is the diagnostic value of an MRI and a mammogram in children treated for childhood cancer? And the other question is, if we do surveillance, will that have a better result on the survival? So can we have a result on the mortality? So can we identify early treatment? Because the main topic for guidelines is that we would like to focus on surveillance of late effects that are treatable. So we will not focus on our guidelines on questions, do we have an asymptomatic abnormal of renal function if there is no treatment at all? We know there is some treatment, so we will formulate that question. But another important one is that we saw for pulmonary function that if we cannot offer a patient a lot after they have been radiated to the chest, that we cannot offer a lot for pulmonary toxicity, then we have not to screen a lot. So that's an important thought about the guidelines. So the question here is, what is the risk of breast cancer in KAYA survivors treated with chest radiation compared to no chest radiation? The second step of evidence-based guideline methods is to look to the evidence. And we have different steps for the search for the evidence. The first one is to develop a search strategy for PubMed. Now, we have already some standard searches in our PanCare group, but sometimes we have to adapt it, but that's a lot of work. Then we have to think about inclusion criteria, which papers would we like to select. We will make evidence tables, we will look to the bias in the studies, and then we will also make conclusions of evidence. The third step in guideline development, and then especially the evidence-based guideline development, is to formulate a recommendation. And we are happy that we have at the moment an international methodology how to do this, and that's the GREAT methodology. And that's really nice because here we take different aspects of the evidence. And a good example was the dexroxane. So if we look to the evidence, we have a lot of papers, but then we have to think about the potential benefits and the harms, and we have to balance it. So we have to see how many benefits are there, how many harms, how do we value that? Then we have to think about the costs, and of course, what is important for patients. So that will be taken into account when we formulate the recommendations. And the essential conclusion for evidence-based guidelines are that it are transparent decision documents. So you can see how decisions are made. Within PanCare, we have also consensus-based guidelines. Now, these guidelines have no systematic evidence summary, but we use the evidence from books or the expert knowledge. There is no systematic process to formulate the recommendations. So it's more that we sit around the table and somebody is saying, oh, I would like to do it like this. And the other one is saying, no, I would like to do it like that. So the process is much shorter. We try to write down really clearly how we made the decisions, but it also saves time, because if you have a late effect that's not very prevalent and also not very relevant, then it will be stupid to spend 1 year to look for all the evidence and to have many discussions together. And then we can do a consensus-based guideline. So in general, we can use consensus-based guidelines when there is no evidence available. The fourth question is, who is developing guidelines for survivors? Now, we are very happy when we started with PanCare that we were able to get a grant from the European Union. That was PanCare Surveillance, led by Lars. And it was so nice because there we have already a work package for guideline development led by Rod Skinner. And at that moment, we also started the worldwide, the global collaboration in international guideline development. And that was possible with thanks to the funding from the EU. Then we have PanCare Live, PanCare Follow-up, that's another European project, PanCare Surpass. I will tell a little bit more about that later on. And then we have a global project, what I said already, and that's the International Guideline Harmonization Group. And with this group, we are making the evidence-based guidelines, and these are the basis for the European guidelines also. So when we look to the European guidelines, then we have PanCare SurveUp guidelines. That's the first project. That's about the transition, not translation, this transition to care from children to adult care, for example, from end of treatment to follow-up care. It's about the models of care, it's about health promotion, and also we contributed to the International Guideline Harmonization Group guidelines there. Then we have the PanCare follow-up guidelines, and these are European guidelines for survivors 5 years after diagnosis and they are covering all the later facts. And this is a very important publication for everyone. So if you would like to be up to date, please look at this publication. It's written by Rebecca van Kalsbeek, and it's published last year in the European Journal of Cancer. And here you can find all the guidelines and the background where the recommendations are coming from. Be aware that these recommendations will be updated, so keep always an eye on the Guideline PanCare website, where we will give updates of the recommendations. But this is a really good starting point for everyone who would like to know something about survivorship care. Then we had another European project that was PanCare Live, and in that project we developed the global guidelines for fertility preservations, and René Mulder was the first author of these publications, and it was really nice because these were 3 publications in the Lancet Oncology last year. So if you would like to know more about fertility preservation, take a look there. And then we have the PanCare Surpass guidelines. So that's the new project from PanCare, the EU-funded project. And in this project, we will be able to develop European guidelines for the end of treatment until 5 years after diagnosis. I think guidelines could be very helpful to get an overview of all the evidence, because when you have a guideline, then you see a summary of all the publications. So not only the publications of our group or another group, but all the publications together. And we will give conclusions for the evidence and also recommendations for research. So it's a good starting point for everyone who would like to know more. Then we have the International Guideline Harmonization Group. So that's what we are doing together with people around the world. And PanCare is leading together with St. Jude and Princess Maxima Center. And we developed at the moment 20 guidelines already, and they are all published in high impact journals. We have also a website that I will show at the next slide. And important to know is that there are more than 400 experts involved. And it's so nice because everyone is doing that in their free time. So I think we have 2 or 3 meetings, Rod, every week, and with many people around the world. So if you're interested, let us know. At the moment, 8 panels are preparing publications. So Rod will tell you a little bit more about some of these guidelines. So for the next steps, it will be very important to implement and update. That's the focus of many new grants and a lot of new work that we are doing. I think implementation should get more attention, and you will hear also about it from Ricardo, because Surpass is one of the perfect tools to implement guidelines. To be updated, please take a look to the PanCare website where the guidelines are mentioned, and Rod and I are chairing the guideline group within PanCare. So if you have questions, come back to us. And if you would like to have more insight in the evidence-based guidelines, so all the evidence behind, take a look to the website of the International Guideline Harmonization Group. So Rod, it is exactly 15 minutes after 11, so you can take it over now. We cannot hear you, Rod, so you have to unmute yourself.
Right, sorry about that. You just sort out my mute. Right. So, I mean, first of all, thank you, Leontien, for setting the scene for the second part of this talk. And also, thank you very much to Katrine and your colleagues for organising this excellent education course and for asking us to give these presentations. So I'm going to just tell you a little bit about some of the guidelines that have been produced and really a very brief whistle-stop tour through some of the highlights to give you an idea of the scope and the content. I'm not going to go into detail in any of these because we haven't got time, but exactly as Leontien has just said, please do contact us if you have any questions at all. So the two broad areas of guideline development that are relevant to us today, the first one is delivery of long-term follow-up care. And as Leontien has indicated, PanCare SIOP has worked on this with two guidelines published. The first for transition, and this is really defining what transition is all about. And the second about models of long-term follow-up care. Work is ongoing to develop health promotion guidelines, particularly regarding physical activity. So these are the transition guidelines. As I say, this is really focusing on what transition intends to achieve and what it should be all about. And there is a separate guideline that will focus on the performance of transition, which I hope will see the light of day in the next year or so. So this first part of the transition guideline was published in 2016 in the European Journal of Cancer. And the important outcome from this was a PanCare SIOP statement for what transition is all about. And you may well recognize this, certain important words such as an active, planned, coordinated, and comprehensive multidisciplinary process, and that it should be flexible, developmentally appropriate, and consider all different aspects of the needs of survivors. So really we're trying to set the scene with that. Now, the second guideline from PanCare SIOP on delivery of care was about models of care or organisation of long-term follow-up care. And this produced some recommendations covering various aspects of this topic, including, for example, organisation of long-term follow-up care, who should be involved, and what the components of care should be. And the next slide just shows a bit more detail about some of the components of care. And for example, recommending that long-term follow-up care should include surveillance, prevention, that there should be facility for coordinating survivors' care, that it should involve education for professionals and for survivors and their families, and also a component for research as well. And that an individual survivorship expert centre should provide a survivorship care plan for the survivors, it should provide education, and it should make a plan for transition. So all fairly obvious and standard, but this is an important document to actually state that these are the evidence-based recommendations. Moving on to late effects surveillance, and these have been produced within IGHG, with input from PanCare SIOP, and within PanCare follow-up, as Leontien has indicated. And there are actually 15 published or in-press guidelines from IGHG, several with all with strong PanCare involvement, a wide range of topics, and published in a lot of high-impact journals over the last 8 years, as you can see there. And I'm just going to highlight just a small number. So this was the first breast cancer surveillance, so subsequent breast cancer we're talking about here. First guideline published in the Lancet Oncology in 2013. And I'm just going to show one aspect of it here because I'm going to talk about the update later. But basically this recommended strongly that survivors who'd had more than 20 gray of chest radiation should have breast cancer surveillance. And the less strong, but still saying reasonable to perform surveillance in those who received 10 to 19 gray, and the possibility that it may be reasonable for those who received lower doses. More about this later. I'm going to focus more on the cardiomyopathy surveillance because this actually shows you the sort of aspects of surveillance that we cover in these guidelines. And Leontien's given you some idea about how we produce this. So this is the Cardiomyopathy Guidelines, published in Lancet Oncology in 2015. A general recommendation that anybody who survivors treated with anthracyclines or chest radiation and their carers need to be aware of cardiomyopathy. We needed to define risk groups, so we defined low risk groups and high risk groups, and then obviously the moderate risk group in between. And these are, I think, standard and well accepted definitions with the doses that you see there. And high risk also includes those who receive both anthracyclines and chest radiation. So if we consider who needs surveillance, and if we think about anthracyclines, then again, a strong recommendation for those treated with a high dose, meaning greater than 250 anthracyclines, taking into account the dose conversions, which I know Lars touched on earlier on. Surveillance is reasonable for those treated with moderate dose, so that's between 100 and 249 milligrams per meter squared, and maybe reasonable for those treated with lower doses. Again, this is being reviewed. I should tell you that the Cardiomyopathy Guidelines is being updated at the moment, but this was the position in 2015. So in terms of chest radiation, surveillance is recommended for those who receive high dose, meaning 35 gray or greater, and maybe reasonable for those treated with moderate dose, so greater than 15 and less than 35 gray. And we couldn't make a recommendation for those treated with lower doses of chest radiation. And for the combination of treatment, it's recommended strongly for those who receive moderate dose anthracyclines and moderate dose radiation. In other words, the combination of those two treatments. In terms of which modality, a strong recommendation, the echocardiogram is recommended due to its characteristics and its widespread availability. Radionuclide angiography, so that's mucus scans and so on, or cardiac MRI, may be reasonable if you have a survivor in whom echocardiography is not feasible or optimal or available for whatever reason. Blood biomarkers, so for these I mean troponins and natriuretic peptides, they're not recommended as the sole strategy for cardiomyopathy surveillance. However, their use in conjunction with imaging may be reasonable if you've got somebody where you suspect that they have got symptomatic cardiomyopathy with borderline cardiac function, and you want to look into that more. But that's taking a step on beyond surveillance a little bit there. How often should you perform surveillance? Well, for high-risk survivors, it's recommended that it starts no later than 2 years after the last cardiotoxic treatment has been finished, and it's repeated 5 years after their initial diagnosis, and then every 5 years. But it may be reasonable to perform it more frequently for higher risk, in other words, higher dose survivors, and it may be reasonable to perform this cardiomyopathy lifelong. There are similar but less strong recommendations for medium and high risk survivors, particularly in terms of whether the surveillance needs to be lifelong. Again, this is being developed further in the updated guidelines that are in progress. I'm not going to go into these aspects in detail, but just to say that the guidelines also cover how often surveillance should be performed in moderate and low risk survivors, as I've just indicated. Also how often in pregnancy, and it also talks more about limits of physical activity. But an important aspect is what do you do if abnormalities are found, and there's a clear and strong recommendation that you refer to a cardiologist. So another aspect of cardiac toxicity is coronary artery disease surveillance. And this was recently published, and the type is very small here, so I'll help you. But in terms of surveillance, we're unable to make a recommendation for routine primary coronary artery disease surveillance because there simply isn't enough evidence to back up any recommendations on this. But we do recommend surveillance for modifiable cardiovascular disease risk factors in those individuals who are at risk of cardiovascular coronary artery disease. This is a tricky area. So subsequent neoplasms of the central nervous system, this was recently published, and basically we're unable to make a recommendation for routine MRI surveillance for asymptomatic survivors who have been treated with cranial radiotherapy. because there isn't enough evidence to tell you whether early detection of these neoplasms by MRI will reduce morbidity and mortality. Obviously, it's a different matter if somebody has symptoms, in which case clearly they need imaging. So the bottom line is that the decision for whether MRI surveillance should be undertaken needs to be a joint decision between the survivor and the healthcare provider after very careful discussion of the risks and of the potential harms and benefits of MRI surveillance. There are several other surveillance guidelines that are nearing completion, notably in the top 3 that I've listed there. There are others that are in progress and a further one that is planned, as you can see there. And again, very happy to talk to anybody about any of the planned work coming up. As Leontien has again indicated, there are other survivorship relevant guidelines that have been produced and are being developed by IGHG. Leontien mentioned the fertility preservation ones. We also produce guidance for survivors about their risk of severe disease with COVID-19 and other related factors. And again, as Leontien has told you that we are currently working on a cardio protection with desmosoxone guideline, and also one for growth hormone treatment in children with neoplasms or cancer predisposition syndromes. Leontien also mentioned the PanCare follow-up guideline, which includes consensus-based recommendations where we don't actually have evidence-based guidelines already available. Together, if we add the IGHG evidence-based guidelines to the PanCare follow-up consensus ones, that you come up with the PanCare follow-up recommendations, and Leontien highlighted this publication to you. And this is just a very small excerpt from the main table in that paper. So looking at thyroid function problems, again, it indicates in the second column which survivors are at risk, and then in the right-hand column, what tests should be done and how often. Guideline updates have been performed and published for secondary breast cancer, and cardiomyopathy, as I've indicated, is in progress. And it's very important to tell you that the PanCare follow-up project is developing a living guidelines tool which will simplify and make more consistent the process by which these guidelines can be updated as new evidence becomes available. And finally, this is the updated breast cancer surveillance guidelines. And there are some important differences between the first guideline published in 2013 and the second one published in 2020. For example, there's now a strong recommendation to perform breast cancer surveillance for survivors who've had more than 10 gray of chest radiation. And there are other important differences as well. And the final aspect is implementation. And this is really essential if we're going to be able to change and improve clinical practice. And we've got to acknowledge that individual centres and countries' practice is variable at the moment. But the SURPASS project, which you're going to hear more about in a minute, is leading the way, and also PanCare follow-up is also going to help to make more widespread implementation of guidelines across Europe. So really, from the 2000s, where we had several national guidelines, but which unfortunately, so I should have said there, had some differences, as you can see, with different recommendations. We're now in the situation in 2020s where we have rigorously developed and harmonized guidelines. And the main aim of these is to improve the quality of care, health outcomes, improve healthcare decisions, and to basically eliminate unnecessary components of care. And ultimately that will probably reduce healthcare costs as well. So thank you very much indeed for your interest. That I know has been a whistle-stop tour, but if there are any questions, please let me know separately. These are just supplementary slides in case there's any questions.